Hi, my name's Caleb Gaede, and the title of my poster is simply Diabetes and Depression, and we're going to take a quick look at the relationship between the two. So my PICA question is, do patients with diabetes mellitus who are diagnosed with depression have better glycemic control when the depression is treated? Well, let's take a look at why this is important. So first of all, diabetes affects 400 million people worldwide, and just over 1 in 10 Americans have diabetes. Depression is also one of the most common mental health disorders, with over 16 million Americans reporting at least one depressive episode each year. So combined, these two are some of the most prevalent diseases that healthcare workers will see in the hospital. Also, the prevalence rate of depression is more than 3 times higher in people with type 1 diabetes and nearly twice as high with type 2 diabetes as those who do not have diabetes. So what's the literature say on this? Well, differentiating between diabetes related to stress and major depressive disorder is necessary for proper treatment. So depressive related distress is defined as the patient's concern about self-management of diabetes, perception of support, emotional burden, and access to quality healthcare. And so this is basically like the stress of having diabetes without being clinically depressed. And about 50% of patients with diabetes, they actually remain undiagnosed and untreated for depression, which is a pretty big number. So what can we do about this? Well, screening for depression is recommended for all newly diagnosed diabetics. We have a couple different scales. We have the WHO-5, the PAE-20, and the DDS-17. And these are all screening tools specifically for diabetics. And it kind of differentiates between depression and diabetes related to stress. And it can help healthcare workers kind of know which direction to go in providing treatment. So we also found that social support was found to affect patient behavior and in turn resulted in better diabetic outcomes. However, evidence that treating the depression in diabetics resulted in better glycemic control is mixed. So what I mean by mixed, well, many of the studies I found stated that they were not big enough to give a definitive answer on this question of whether or not depression causes a direct increase in glycemic control. I did find one study that showed that depression did not cause a decrease in glycemic control over a 2-year period, but the study did admit that the sample size and time of the study were not sufficient to know for sure. However, many other studies I found did indicate that there were negative outcomes with patients diagnosed with both depression and diabetes, and they were all recommended treatment for the depression. This is because improved depression leads to better patient outcomes. So what are improved outcomes? Well, if the person has their symptoms of depression treated, they're more likely to be motivated to cook a healthier meal, exercise, take care of themselves in a way that would help glycemic control. So for the QSIM competencies, we've got a couple different ones. We have teamwork and collaboration. You know, we have different specialties and the healthcare provider, they may be required to work together to treat the patient. So like a diabetic specialist and a psychiatrist would come together. Evidence-based practice, we know that studies show that patients with diabetes should be screened for depression with a couple of the different scales I listed earlier. And patient-centered care, keep the patient up to date and plan, keep them up to date on the plan and allow them to make some decisions to feel like they have some control. You know, this could help with the depression. So for the recommendations, we have a couple different ones. We have standardized a screening tool for diabetics. This would help with the research and with you know, healthcare workers overall. The 3 ones I listed earlier, they're all great. I don't really know which one would be better or worse than the others. But if we had one, that would kind of help standardize the research. Also, larger studies involving diabetics and with depression. This way, we can get better answers and over a longer time frame too. As I mentioned, the one that kind of went against my other studies, it was only over a 2-year period, which I don't think is that quite that long. And also, we should examine different types of social support, such as the use of social media. We know social media can lead to a lot of negative health outcomes, but you know, maybe we can use it for some good. So in conclusion, depression and diabetes, we know that they are related, and we know that we should be screening all diabetic patients for depression, especially with these more specialized tools. Also, we know that social support is useful in both the treatment of depression and the outcomes of diabetes. So overall, I think we know enough about diabetes and depression to provide adequate treatment to our patients, but putting these treatments together is the goal to truly provide for better outcomes. Thank you.